Okay, here to finish finally the discussion on immunity. So we've looked at the innate system, the adaptive system, 1 and 2. We look now at the antibodies. So your immunoglobulin classes. We kind of looked at how the cell-mediated and the humoral branches of immunity kind of overlap, but are also integrated. We learned about our helper T cells, our cytotoxic T cells, our regulatory T cells. All of those are going to be important to understand this discussion here. So let me get into our last bit of sort of immune issues, immunodeficiencies, um, just the different aspects of autoimmunity, that kind of stuff as well. So let's begin with the immunodeficiencies. So as the name implies, there is a deficiency. There's a inadequate amount, inadequate response of an immune response, I guess, if you will. So immunodeficiencies can be congenital. We can be born with these immunodeficiencies. They can be acquired as we progress throughout life. And basically they will have our immune cells malfunction. The immune cells may be inadequate amounts. The phagocytic cells don't do their jobs properly, and or complement fails to do its job. Complement loses its ability to generate the membrane attack complex and not lyse cells. So all of these generically fall under the idea of an immunodeficiency. So we'll start with the worst one first, I guess, right? Severe combined immunodeficiency syndrome, also known as SCID. So SCID is a genetic defect. So the poor child, I don't know if you ever watched the documentary, it's an old documentary about the Bobo boy. This child had SCID, basically didn't, in essence, have an immune system. So very marked deficit in the B cells, so not producing enough antibodies, not producing enough memory cells, and deficiency in T cells. So both branches, humoral and cell-mediated, are very deficient. There's a lot of abnormalities in the receptors. I didn't really get into that too much in the last discussion. The receptors, the binding receptors, the MCH classes, the cellular communication between these two branches. There's a lot of other metabolites. There's other, defective enzymes that don't do what they're supposed to. So in essence, you have a child that has no immune system, right? And they're born like that, and they don't have the ability to manufacture their own immune system. So if they're not basically put in a sterile environment, anything and everything that enters their body will have sort of free roam of the body, and our body will not be able to fight off those antigens. So if not treated, if not dealt with, it will cause a very, very early death in an individual. So SCID. Hodgkin's disease, we've mentioned a little bit. This is an acquired immunodeficiency. We talk a little bit about Hodgkin's disease with the lymphatic system. Now we address it properly. Hodgkin's disease is actually a cancer of the B cells. So it's these B cells that start aggregating abnormally, and you think, well, that might be good. We have a lot of B cells, which makes a lot of antibodies, but that's not how it works. The B cells become cancerous. The B cells start to proliferate, but incorrectly, and they're not valid. They're not generating proper memory cells. They're not generating proper plasma cells. They're just too many abnormal B cells that fail to secrete the proper amount of, again, plasma cells and ultimately antibodies. So if we're not generating enough antibodies, that leads to immunodeficiency, and we don't, actually by depressing. So if we're clogging up the lymphatic tissue with cancerous B cells, it's taking up a lot of space for the training of T cells, for the sort of a lot of these macrophages that hang out in these lymphoid tissues. So it just clogs up the lymphatics and doesn't allow them to drain properly. It doesn't allow them to serve as these surveillance sites for the lymphatic components and ultimately the immune components. Something that I think a lot of you know about. I'd be very shocked if you didn't know about AIDS. But AIDS, we know, is acquired immunodeficiency syndrome. And we know that AIDS is sort of the long-term effect of an HIV infection, right? Human immunodeficiency virus. So what AIDS is basically, so the virus infects its host, right? The virus cripples the immune system by interfering with the activity of the helper T cells. Again, this is a big deal. If you recall from the last discussion, without helper T cells, there is no immune response. So helper T cells are completely necessary to orchestrate the entire immune response. So the virus is quite sneaky. It goes in and attacks the helper T cells. And by diminishing just that one component of immunity, it sort of collapses the entire immune response. So in essence, an AIDS patient, in essence, becomes almost like a SCID patient, right? Except the SCID patients were born with this. The AIDS patient has acquired this deficiency because of the HIV virus, right? And basically, nobody ever dies of AIDS. On their death certificate, it never says cause of death AIDS. No, they get overwhelmed by something relatively simple, right? A pneumonia, a yeast infection, some other little infection overwhelms their body. Something that they should normally be able to fight off, they cannot because of this immunodeficiency. So I think you learned this in health class, but we know that AIDS is preventable, right? If we don't get the HIV virus, there's no way that we can generate this type of AIDS here, right? So the HIV virus, we must be conscious of, is transmitted through the bodily fluids, blood, semen, vaginal secretions. We know that through blood transfusion, contaminated needles, unprotected sex, these are ways that the AIDS virus can, or the HIV virus can infect the body and then ultimately produce AIDS. There's a lot of new medications, new prophylactic medications, interferon treatments, a lot of things going on in the year 2020 now that really have had a very positive impact on these HIV patients, right? So it's not as hopeless today as it was in the early 1980s. Yeah, so it was, if you had AIDS in the early 1980s, you could pretty much know you're not going to last very long. But today, with medication, with knowledge, the outlook for these patients has become much brighter. So we know the HIV virus destroys the T helper cells. And by destroying T helper cells, we cannot integrate with cell-mediated immunity. And in essence, there's no immune response generated. So again, if you know a little bit about just the progression of the virus, right? So the symptoms take a while to appear. And then once you have the virus, unfortunately, you have it to the end of your life. It's not something that like the flu comes in, or like Ebola comes in, makes a mess of the system and then leaves. No, AIDS, this HIV virus will linger, you know, in a very, very chronic type of way. Some of the new medications that they use, you'll have an assignment that deals with some of these treatments as well. Okay, so we're going to shift gears a little bit, right? We've looked at sort of deficiencies of the immune system, where the immune system isn't doing enough of its work. Now we look at the autoimmune diseases. In this situation, the immune system is maybe working too much. It's working overtime, and it's attacking the wrong type of things, right? So the immune system loses the ability to distinguish self from foreign. So the guard dog that normally didn't bite the kids now starts to bite the kids. The guard dog loses its sight, its hearing, is just getting senile some way. So the guard dog just starts biting everybody. That's kind of what an autoimmune disease is. So we start to produce auto antibodies that start to destroy non-infected, not damaged, just normal self tissue. And some of these conditions are things like multiple sclerosis, type 1 diabetes, systemic lupus erythematosus, we know it's just as lupus, rheumatoid arthritis. So in these conditions, the bad guy is not a virus, the bad guy is not a bacteria, a worm. The bad guy is our own immune system. Our own immune system is the one that's going and attacking our healthy tissue. So in order to stop all of these conditions, we would have to kind of stop the functionality of the immune system, which, okay, good. We can, make people with rheumatoid arthritis' life better. They're not going to have arthritis if we dampen their immune system. But if you can logically, kind of figure out, well, if we dampen the immune system, no more arthritis, that's good. But what happens with all the other bacteria that kind of enter into the body? So that's not a good strategy. We can't just dampen the immune system. We can't be like a SCID patient or a patient in chemotherapy. No, we need our immune system strong so that it can go and fight off foreign invaders. And again, we know that it is attacking now healthy tissue, so that becomes a significant issue. These are some ideas of how autoimmunity arises, right? So there may be a mistake, right? Foreign antigens might look similar to self-antigens. So it's a mistaken identity, right? New self-antigens may appear. So our own cells might start to have some sort of mutation, and we start to manufacture the different type or a new type of self-antigen. And the immune system is doing its job, actually, right? It doesn't recognize this new antigen, and it attacks that healthy cell. Now we talk about haptens. Haptens can enter into the body and change our own self proteins and make them targets for this autoimmune aspect. This is very common in a lot of the allergies. There may be self-antigens that are released into new areas of the body. So if we have, normally the blood-brain barriers, there's never any communication between antigens of the brain tissue. But if there's some sort of tear in the blood-brain barrier, some of those cells leak out, some of our immune cells leak in, then we have this sort of novel, this new antigen that our immune system is not used to seeing. So it may trigger autoimmunity. Again, hypersensitivities, the allergies. Again, haptens can be linked to this. Mutations can be linked to this. Overworking of the B cell or of the basophils, overworking of the IgEs. A lot of these things can be linked to allergies. Hypersensitivities. So there's allergies. There's our IgE. There's our basophils. In the worst case scenario, if there's so drastic of an immune response, if our own immune system just completely goes crazy and attacks our own tissue, anaphylactic shock may be a risk, right? So, and this is a systemic response. So we don't just have an allergy where we got the poison ivy per se. We have a systemic, just throughout the entire body. Basophils go crazy, release tremendous amounts of histamine. We have constriction of the bronchioles, which makes it difficult to breathe per se. We have vasodilation of the blood vessels, which is going to drop blood pressure. We can become very low blood pressure. And basically, if there's not enough cardiac output in the system, death could occur in a very, very short time. So how do we treat this? That famous EpiPen, you'd have to inject the system, flood the system with adrenaline, with epinephrine, and get everything sort of reversed, get the blood pressure higher, dilate those bronchioles of the lungs, get oxygen circulating back again. And it's been a lot of economical and political, I guess, chaos. I don't know if that's the right word, but with EpiPens. EpiPens used to be very easily available, very cheap. When I started at UTEP, a while back, you could go cross the bridge to Juarez. You could get EpiPens for $9, right? They didn't care. You can bring back as many as you want EpiPens. We'd have them there. If we ever got bit by a venomous snake during our research, I'm going to go into anaphylactic EpiPen, right? Now it's crazy. The regulation and the cost of EpiPens is very, very, very high. And there doesn't seem to be a good biological reason. Again, it's based in economics, based in politics, why the cost of EpiPens is so incredibly expensive today. But epinephrine, EpiPens there. If you are allergic to bees, if you're allergic to common things around the environment, it may be a matter of life or death that you might need to carry these EpiPens in case you do get stung by that bee. I don't know your allergy situation, but if you are very allergic, it may be something that you may look into, the EpiPens. So with that concludes our broadcast day. That concludes our whole chapter now on immunology. That gives you a lot to sit and process. Your homework assignment has already been uploaded, and keep an eye out for the next take-home activity that I'm going to send out later today. So with that, y'all have a good rest of your day, and I'll be seeing you next time.